All right, so it is so good to be with you all. It's an exciting time for Alzheimer's research, and I hope that you'll feel the same way at the end of this. We're going to talk about a couple of new treatments that have come in the last year or two, and what that means for all of us as we think about Alzheimer's disease. So I want to start with some background, and I always like to explain where Alzheimer's disease, the name, comes from, because really dementia and Alzheimer's disease, it's been around a lot longer than 1906, but that's when it was named. Prior to that, it was really senility. We heard a lot about, and I think people still use the term, senile dementia. But this patient, Augusta Dieter, she was only in her 40s when she developed some memory loss, delusions, and would go in and out of these temporary vegetative states. And because of her age, because she was so young, she was studied by a psychiatrist. So because of her symptoms, she was admitted to a mental institution, and her husband just really couldn't look after her anymore. And she would repeatedly say, obviously in German, but I have lost myself. And so a physician at that mental institution was Alois Alzheimer. And he was very interested in her case because she had the signs and symptoms of senile dementia, but was only, at the time she was admitted, 51. So Alois Alzheimer, he was a psychiatrist, but also a neuropathologist. He studied people in the institution, but then he studied their brains. And so he did monitor the course of her disease. And then when she died, he examined her brain. And what he saw when he looked at her brain is essentially what we still use as diagnostic for Alzheimer's disease. And that is these two hallmark pathologies in the brain. One is plaques. We're going to talk about amyloid plaques. And the other one is tangles. And the top two drawings that you see there, these are actual, back in 1906, there were no cameras attached to microscopes. You had to draw what you saw. And so Alois Alzheimer drew what he saw when he looked at Augusta Dieter's brain. And so what he was describing here were these plaques. These were cotton wool ball looking clumps of protein that sat outside of the cells. So these weren't inside the brain cells, they were in between the brain cells, in the space between them. And then the tangles were also present, but and they are also clumps of protein. But in the case of tangles, these clumps of protein sit inside the nerve cells of the brain. What's unique about those is that when the nerve cells die that contain the tangles, the tangle remains. And so sometimes they're called like tombstone tangles, because essentially they're telling you where there once was a nerve cell. This on the bottom, this is not an Alois Alzheimer drawing. This is a computer rendering of what these plaques shown in those round kind of ball structures. Those are the plaques. And then you can see the black kind of dense, and it does look like a tangled knot that's sitting inside that nerve cell. So those are the tangles. And again, this is still diagnostic. If you have plaques but no tangles, you don't have Alzheimer's disease. And if you have tangles and no plaques, you don't have Alzheimer's disease. You have to have both of those. So right now, and for the last 25, 30 years, the only treatment that has been around for Alzheimer's disease is what are called these acetylcholinesterase inhibitors. These are the drugs like Aricept, donepezil. There's a whole host of these now. They all work through the same pathway. They are all, so there's a certain group of nerve cells in the brain that use a peptide called acetylcholine, not a peptide, but a chemical called acetylcholine, to talk to each other. And so very early in the 80s, it was shown that these nerve cells that use acetylcholine, they die off quite early in the disease process of Alzheimer's disease. And they're very important for memory. And so these drugs, they block enzymes that break down acetylcholine. So what that really does is it makes more acetylcholine available because it's not getting broken down as much. And so the nerve cells still die, but this helps the nerve cells that remain function a little bit better. And so it's purely a symptomatic treatment. It's not modifying the course of the disease in any way. But you talk to patients, it does give them a meaningful benefit. And we always use this average of 6 months. So, and it is truly, you know, an average of 6 month benefit. The challenge a little bit is that we don't fully understand why, but some people will actually show no response to these drugs. And then other people will benefit from these for several years. And so, while we say an average of 6 months, that's an average of a very broad kind of range of duration of treatment, right? So typically these are prescribed when people start showing symptoms of mild cognitive impairment, and when it's suspected that it's Alzheimer's disease. And even though the benefit only lasts that period of time, if patients aren't having any adverse effects, they tend to stay on these drugs. And then there's another drug that is called memantine. Namenda, I think, was the trade name for this when it came out. This came out in the early 2000s. This is another symptomatic treatment like the last one. So it doesn't change the course of disease, but it does give you a little bit longer benefit. So what typically a doctor will do is they'll prescribe one of those we just talked about, the acetylcholine drugs. When a patient starts to decline again, they'll usually add this on as another treatment. And again, on average, they might be another like 6 month stabilization, but same as the other one, that is quite a broad range. And drug companies now are formulating these together, this one and the last one we talked about. But this just helps prevent what we call excitotoxicity. So if you have too much of this other chemical around called glutamate, if there's too much, it can kill the nerve cells. And so there does seem to be a problem with glutamate in Alzheimer's disease. And so the idea is it doesn't block normal glutamate transmission, but if there's too much glutamate, memantine will reduce that. So it keeps the nerve cells healthier for a bit longer. So one of the big questions that we all have is why don't these drugs really work, right? So we have the cholinesterase inhibitors, we have these NMDA antagonists called memantine, and these are all used in clinic now, but at best they're providing a moderate benefit. So we all, obviously as researchers, we all want to know why don't they really change the course of disease. So this is what the main hypothesis that a lot of us have been working on for, this was first proposed in 1992. So I guess a long time now, 40 years. And the idea is that you have the beginning of Alzheimer's disease is when you have increased production or reduced breakdown of this protein called amyloid beta. And that is the protein that makes up those plaques that Alois Alzheimer saw and that we still use as diagnostic for Alzheimer's. And so the plaque seems to be the first thing that happens in the brain. You start to build up these plaques in the brain. The nerve cells aren't happy about this. It blocks their ability to talk to each other, and it can cause like a stress on the nerve cells. And when they get stressed, this protein called tau is abnormally processed by the cell. And when that happens, it forms these tangles. NFT stands for neurofibrillary tangles, but they're just the tangles. And the tangles are inside the nerve cells, if you remember, right? And so because that's inside the nerve cells, now those nerve cells that get those tangles, they don't function at all anymore. And so now they die, those nerve cells die. They stop talking to each other. And when that happens, that's when you get the memory loss and all of the cognitive deficits that we see in our Alzheimer patients. And so if I were to ask any of you, right, if you wanted to design the perfect drug for Alzheimer's disease that would cure or treat the disease, which one of these things you would target, you would want to come at the top of this cascade. You would want to try and block that beta amyloid or the plaque, with the hope that if you block that, then all of those downstream things would stop happening too. And actually that's what drug companies and us researchers in the lab have been trying to do for 30 years now. And so over that time period, we've also learned a lot about how Alzheimer's disease progresses. And so this graph shows you when all of the changes happen. And so if I can get my pointer up, hopefully you can all see my pointer. So the red line here is the brain building up this amyloid beta protein. What you see then is that keeps going and going and increasing and increasing. And it's almost reached its maximum when you reach this line here, this first dashed line. And that first dashed line is the very first time you start to see symptoms in patients. Before that, people are completely normal cognitively and, with respect to their memory. So by the time someone starts to show those earliest symptoms, they already have a whole lot of this plaque in their brain. The blue line is the tangles, right? And so the tangles come after, they come later. But if you look at the line for the tangles, you're probably already around 65 to 70% of the maximum amount of tangles you're going to get by the time you have symptoms. So by the time someone really starts to show symptoms, they already have a significant amount of plaque, significant amount of tangle pathology, and their brain has started to shrink, which is the green line here. So there's nerve cells are dying and the brain is starting to shrink. The purple line here is where memory is, and then the green line here is clinical function, which really is dementia, is your ability to perform daily tasks, live independently. So that obviously is the last thing that changes in patients. So this, as we've learned more about this is a challenge, because a lot of times with drugs, we've tried to obviously, if you don't know someone has plaques in the brain, you can't treat it. And so the earliest thing we've been able to detect up until recently is that cognitive decline. And so we have been trying to treat people in clinical trials when they already have all of these changes going on in their brain. And I think that is a big reason why so many of our drugs have been failing. And so what are people trying? How are we trying to change this? And this is going to lead me into some of those new drugs that are on the market, coming on the market. So there's a lot of different immunotherapies, and I'm going to talk about a couple of those in more detail. So these are antibodies. And, you know, you see all these drug adverts on TV, right? There's so many drug adverts on TV for different things. If the name of the drug ends in MAB, it's an antibody. And they're used for all kinds of things. They're even used to treat migraine now, you know, colitis. There's many different antibodies used for cancer treatments. So in Alzheimer's disease, people are using antibodies to try to target those plaques or target the tangles. And the plaques are where we've really been able to move the needle on some of these things. So the other thing that we've had a lot of trials with, and sadly a lot of failures, is drugs called secretase inhibitors. And so these are drugs that reduce the production of the beta amyloid that makes the plaque by blocking the machinery, basically, that produces that protein. And so the drugs work to reduce the production of that protein that makes the plaque. But unfortunately, though, that machinery is responsible for a lot of other things in the body as well. And so they've really been plagued with a lot of side effects that drug companies are still trying to work out. A lot of focus now is on inflammation and changing the brain. So the brain has kind of an immune response to these plaques and tangles. And so there's a lot of focus now, although it's earlier, and it's probably not going to come into clinical use for another 5 or 10 years, maybe. But in the early stages of development, there's a lot of drugs that they're trying to look at. If you change how the brain responds to these plaques and tangles, can you improve symptoms and slow the progression? And then the bottom one here, the kinase inhibitors, this is like those secretase inhibitors, except instead of blocking the machinery that makes that beta amyloid protein, this is blocking the machinery that leads to the formation of tangles. And so this is plagued with the same kind of things as the secretase inhibitors. It does help to block that machinery that makes the tangles, but that machinery does a lot of other things in the body. And so there's been a lot of side effects from those drugs. So this immunotherapy idea, so it was the very first mention of this was in a study that was done in mice in 1999. And ever since then, my research has had a lot to do with some of these antibodies and understanding how they work. Lots of other people here at UK, but you know, around the world have been studying these antibodies to get us to the point we're at today with them. And so how does this work, right? So what antibodies do is that they will bind to whatever you design them to bind to. You can get them to bind to bacteria, and that's what our body does. That's how our own body's immune response gets rid of a bacterial infection, is that they recognize that as foreign and they make antibodies to it. So in this case, you can make antibodies to the protein that makes up the plaques, that beta amyloid protein. And so by making an antibody that will bind to that, The antibody binds to the beta amyloid, whether it's in a plaque or whether it's just out there on its own as a single molecule. The antibody binds to it. When the antibody is bound to that protein, it triggers the brain's immune cells to come in and swallow that complex up. And so these immune cells in the brain, they're called microglia, they will receive this signal from the antibody, and they'll come in and they'll just swallow up that little bit of plaque along with the antibody that it's bound to. As of right now, the antibodies that there's two that are conditionally approved, and I think for the foreseeable future, they're going to be given by an intravenous infusion. So that complicates things a little bit. Patients have to come in and receive these infusions. Each one is a little different, but it's about initially, I think every 2 to 4 weeks, and then tapering down to every 6 to 8 weeks. And there's really 3 antibodies that everybody has been talking about of late, but it's important, like they're not all the same. So in the formation of these plaques, the fibrils over here, this would be a plaque. And then these are like, I think of them as like mini plaques. They're little pieces of a plaque. They haven't quite come together yet to form that big clump, but they're starting to cluster together. These are even smaller clusters here. And then this is like a single beta amyloid piece is the monomer. And so lecanemab, or Leqembi is the trade name, mostly binds to these like products that are in the middle. Like they're almost a plaque, but they're just like a little piece of a plaque. Aduhelm, or aducanumab, which was the one that hit the news last year, that mostly binds to plaques. And then gantenerumab is another one that I don't think is going to move forward anymore, but that only binds to the plaques. And so this was amazing. I think when we all saw this, this is what I'm showing here is the drug trial for Aduhelm, or aducanumab. But lecanemab looks incredibly similar, so I'm not going to show both. But this is a brain scan that actually you can see the plaques. You can see those plaques in the brain using this very special PET scan. And this has been a game changer for clinical trials, because now we don't have to wait until someone dies to be able to look at the plaques. We can look at the plaques in the brain of someone who is alive. And so we can look, if we have a drug that is supposed to reduce the plaques in the brain, we can see if it does actually do that, which before this, this was developed in the early 2000s, before this, we didn't have any way of doing that. It was a lot of guesswork. And we know guesswork usually, humans aren't robots, they're not very good at that. So where you see reds and oranges mean that there's a lot of plaque. And the greens and the blues mean that there's really not much plaque, if anything, there at all. There's normally, so you see here through, this is called white matter. It's like train tracks in the brain. For some reason, we don't know why, but this agent does seem to just stick to that, even though there's no plaque there. So you always see binding in these areas, but it's not specific. This is where you're really looking for those plaques. And so before treatment, you can see this individual, lots of plaques through the brain, lots of reds and oranges. This person was on placebo for a year, and you can see the plaques, nothing changed. Maybe actually there's a little bit more red and orange. Someone who was on low dose, actually for a year, there might be some yellows and a little bit of orange, but in general, you can see it's a lot less reds, meaning that there's less plaque. Same here in the medium dose, and in the high dose, you don't really see any red or orange anymore. And so then these are the graphs that they showed when they presented the trial results that just show that reduction, right? So now instead of just looking, they actually can put numbers to how much plaque is there. And so you can see that over time, whether you're low dose or high dose, that plaque amount has decreased. And there were 2 trials for aducanumab. One was called Emerge, one was called Engage, and both trials showed that plaque reduction. Lecanemab or Leqembi has shown exactly the same thing. In fact, it looks like it's better at reducing the plaque than aducanumab was. And so along with that, there was a slowing of cognitive decline, more in the one trial than the other trial, which was interesting and a little concerning, because you would expect, like, they had the same patient kind of population. They chose people with the same amount of memory loss. They had, same numbers of males and females and everything. So they kind of matched, but it looks like in Emerge, for some reason, the slowing was better. So this has changed from baseline. So this is actually some people, the black line is kind of people getting worse over time, and they're on the placebo. And you can see that the people on the aducanumab, they seem to get worse more slowly, but they do still get worse. This isn't, this isn't a cure, but they, like I say, they do seem to slow off. And some people have said, well, it looks like this might be starting to, flatten out. And I think we all hope that that would be the case. But this is where the trial was stopped. And then this one again, like there's slowing of they don't decline, the function, the memory doesn't decline as quickly as the placebo, but there is still decline. This was the data for lecanemab. So now it's flipped. So now the black line is placebo, but you're looking at the slope. And so if you follow that black line, which was placebo, you can see that the placebo group got worse over the 18 months of this clinical trial. And the people receiving the lecanemab, they got worse more slowly. And actually, if you look at, this is 6 months, the first circle here, and this is 18 months, there does seem to be more separation over time. And so the hope is that when people are on this drug for longer, there will be more and more separation. And what that means is more and more benefit over time. So all of this is fantastic. We're all very excited, but there are a few concerns. So this isn't the perfect drug by any stretch. I just wanted to show you, there are some things that seem to affect how well lecanemab works. And so it seems to work better in men than women. So the more shifted towards this side over here, the more benefit, if you like, with the lecanemab. And so you can see that female and male here, it does seem like men benefited more than women, but both have a benefit. there is a genetic risk called ApoE4. And if you have the ApoE4 gene, it does seem like you benefit less than if you don't have ApoE4. There's also a bit of a problem with our trials in that we are very underrepresented for Black and Hispanic participants. So this is actually the number of participants. If you look at the number of white individuals in the trial, we're in the high 600s. Down here were 24 and 20 for Blacks in the placebo versus the lecanemab. And our Hispanics too, underrepresented compared to the general population in the States. So, but then it also seems the older you are, actually, the more you benefit as well. So if you're over 75, you have more benefit than if you're under 65. But there's still a trend towards people benefiting from this. So this is great. These are the side effects that that people are worried about. They're called ARIA, A-R-I-A. Sounds like the opera song aria. But what that really stands for is amyloid-related imaging abnormalities. And these can be in the form of edema, and edema is like liquid, fluid, water, that seems to leak across the blood-brain barrier in the brain. So when you have edema in the rest of your body, it swells, right? If you have edema on your knee, it means your knee is swollen. If you have edema at your ankle, it means your ankle's swollen. So it happens in the brain. So where you see the white on this MRI here, that's where you have kind of water that shouldn't be there. It happens, and in the aducanumab trial, it was 35% of, up to 35% of people in the trial had some signs of ARIA. It may be related to the brain getting rid of that plaque, which would be a good thing. Only about 20% had any symptoms, and that was mostly a headache. Most people, like 3/4 of the people who have ARIA don't have symptoms. And it usually does resolve after you take the patient off of the treatment. In the lecanemab trial, where people had very mild ARIA and didn't have any symptoms, after it resolved, they actually started them back on the lecanemab, and the ARIA did not come back. So there's still a lot we don't understand about ARIA, and actually this is something my own lab is looking at, is how this happens and can we prevent it. So this is one of the limitations. Because of this, the drugs aren't really recommended for people who are on certain types of blood thinners, or if people already have a lot of blood vessel changes in the brain. It's probably not a good idea to go on these drugs, but that is kind of a decision between, you know, a doctor and a patient as to whether the risk benefit is worth it. This was fall 2017, but it still looks very similar. And all I really want to show you here is just like how many drugs are in clinical trials. So, and this is just for Alzheimer's. So we have lots and lots in phase 1 and phase 2. And some of the ones here in phase 3 are now finished. But you can see that at the time, aducanumab was in phase 3. Gantenerumab was in phase 3. And let's see, this band 2401 became lecanemab. So at the time it was in phase 2, but now it's moved forward. So people, we're not just focusing on these 1 or 2 drugs. Like there's a lot of different pathways, different types of drugs that are being looked at for Alzheimer's disease. It's just very few of them make it out of that middle phase 3 circle and actually become successful drugs that you can get from your doctor. So, I think this is something I didn't understand for a long time is why do our trials take so long? So you have really phase 1 is phase 1 takes a number of weeks, and usually the number of people involved in a phase 1 are in the tens, and this is safety. So usually a phase 1 is done in people who don't have the disease you're targeting, usually healthy middle-aged individuals. And then once they make it through phase 1, they go into phase 2. This is a number of months. With Alzheimer's trials, often 12 to 18 months. And usually you have multiple hundreds of patients. And this starts to look at how effective the drug might be in the disease. So people in phase 2 trials have the disease that you're targeting, in this case, Alzheimer's disease. Once you get to so if you make it through phase 2 and you get into phase 3, now you're really looking at a number of years. And so because even though those trials that I just showed you that were phase 3, so for lecanemab, it was 18 months, but it's not really an 18-month study because it actually takes you about 2 years, if not longer, to recruit the numbers of people you need into that trial. And you can't look at any data until the last person has their last dose of drug. So that's why, even though it's an 18-month dose, you're often looking at 3, 4, 5 years for some of these trials to be finished. And it's only after phase 3 that the FDA will look at your data and decide whether or not that drug is worth moving forward. So it takes a really long time. So, why do trials fail? If you look at the numbers, 230 drugs failed in trials between 2002 and 2012. So in a 10-year period, 229 compounds failed. Since 2003, 1,379 trials have failed. This is just for Alzheimer's disease. We think now a lot of this is because of that very long period where people are getting plaques and tangles build up in the brain, but there's no symptoms. So by the time people come in with symptoms and come into a clinical trial, you're trying to undo possibly 30 years of brain changes in a 12 or 18-month clinical trial. So when you start to think about it that way, it's not really surprising that we've struggled so much to get this. One of the key things that has really helped, I think, is what are called biomarkers, right? So unfortunately, with the brain, we can't do a biopsy, right? So if you suspect a cancer, we all get screenings for mammograms and prostate and colonoscopies. And if something looks a little bit off, they can take a little sample and they can look at it under a microscope and they can say yes or no, it's cancer or it's something else. We can't do that with the brain. We can't go in and take a little sample. So what we have to rely on are what we call biomarkers. So this is something that we can look at that tells us what kind of changes are happening in the brain. And so that special PET scan I told you about is one of them. So we have them now for plaques and tangles. We've not had the tangle one for very long, but we do have one now that will let us see tangles in the brain of Alzheimer's patients. And you can see from a normal older adult on the left there to a normal, so cognitively normal older adult, but now they have those brain changes going on already. And then this is someone who now has a lot of cognitive problems. They've got an Alzheimer's diagnosis, and you can see they have very high plaques and tangles. I'm going to skip through this. I don't think we need this. But this is, I think, where a lot of us want to get to. And so this is precision medicine. They're doing it already in cancer. Doctors are now looking at the genetic signature of tumors, and then they can target the treatment to, that genetic signature. And so I think what we're all thinking about now for Alzheimer's disease is really trying to find different signatures that we can measure with different biomarkers, and then we can split out our very mixed population. Like, even though they might all have the same kind of memory loss or the same level of dementia, it doesn't necessarily mean they all have the same levels of plaques and tangles. And it gets way more complicated than that, because there's other things that can cause dementia as well. And so by being able to split people out into these groups, our hope is that we will actually have drugs that will hit each of those different things. And that's where we can actually make a lot of progress. So just to finish on what has been really amazing news in the last year or so, we now have 2 agents that are technically, we can say they're FDA approved. They were granted what's called accelerated approval by the FDA. So what that means is that there is evidence that these agents may have an impact on the disease, and they appear to have a reasonable safety profile. And so together the FDA will grant accelerated approval, which means that now the drug companies can give the drugs, doctors can prescribe the drugs, and start to get a lot more data on the long term. So the idea behind this kind of approval is that, well, okay, instead of the 18-month, right, now we could feasibly have someone on these drugs for 5 or 6 years under this FDA approval, and hopefully see what we all think we'll see, which is increasing benefit with longer duration of treatment. So Aduhelm was approved last year. Leqembi or lecanemab was approved this year, just last month, a few weeks, not long ago, Christmas maybe. And so doctors can now prescribe these. People do have to do like biomarkers for that beta amyloid protein, and you have to check for the ARIA happening. So people need to have regular MRI scans as well, especially in the beginning. And I think a lot of us in the field expect that Leqembi might receive like a full FDA approval later this year, and that would make it more widely available to everyone, and there'd be a little bit less monitoring needed for it. So this is the first drugs ever to be approved that have been shown to change the course of disease. So what we would call disease modifying drugs, first ever for Alzheimer's, and actually the first approved drug in over 20 years for Alzheimer's treatment. So huge breakthrough. I'm sure lots of people have lots of questions about them, which I'm more than happy to answer. These are some resources. I will leave this up while we take questions. I'm always happy to answer questions by email, but the Alzheimer's Association and the Sanders Brown Center website have a lot of good resources, as also does the AARP website. So always feel free to look around, check it out, but also I'm happy to answer questions that people have. And let me stop my laser pointer, and I can see what questions are in the chat, or anybody who is online. Feel free to go ahead and unmute and ask your question.
Hi there. This is Amanda. I have one question, please, and it's about one of your slides. So I didn't know if it would be helpful to.
I can go back if you want to tell me which one it is.
Yeah, I think I can explain it. It's the one that has the placebo, the four pictures of the brain scans, and then there's the placebo, low dose, medium dose, and high dose.
Okay.
Yep, still back. Yeah. I just wondered if you could, and you may have said this and I missed it. Yeah, that's the one. In practical terms, what stage, so when I think about what I know about Alzheimer's so far, personally, I understand it in terms of mild stage, moderate, or moderate to severe, etc. So what would you describe, or how can you describe these patients' brain scans in terms of what stage they might be in?
So in addition to having this amyloid signature in their brain, everyone in this clinical trial had to at least have a diagnosis of mild cognitive impairment. And it was mild cognitive impairment or early AD. They didn't take anything past early AD. So they didn't take moderate to severe into the trial.
Okay.
There's a lot of trials happening right now where we're trying to find people before they have any symptoms when they have the amyloid. One of the big breakthroughs is that it looks like we probably have a blood test for that, which is much cheaper and much more accessible than having to do these scans. Each one of these scans is $5,000.
Wow.
So as far as staging goes, it's really hard, right? Because when we talk about MCI, early AD, moderate to severe AD, what we're really talking about is the clinical symptoms. And with these scans, the clinical symptoms don't really line up with how much amyloid is in the brain.
Right.
So so with the amyloid scans, when someone has an amyloid scan, typically it's either there's a cutoff and you either say it's positive or negative for amyloid. And with these drugs, people actually move from being classed as positive to being classed as negative because these drugs remove so much amyloid from the brain. But that doesn't line up how we would like to see it as far as like in memory, right?
Yeah.
But there's already been so much damage to the brain. So we can't really say that these are stages, because stages refer to the clinical symptoms, not the amount of amyloid.
Thank you. So if somebody wanted to be part of a trial, though, at this stage, would somebody say be excluded from a trial if they were clinically diagnosed with, say, moderate stage?
So the way that the approval, so first of all, there are trials going on right now for people at every stage.
Okay.
So we have trials that are more behavioral symptom type trials for people who are severe Alzheimer's disease. The way, if people are interested in getting these drugs, the FDA approval and the way that's written is that people should have proof that there's amyloid in the brain. So you either have to get one of these scans, or now they're starting to do these blood tests or a spinal fluid measurement. And then the other criteria is you have to be at least MCI. So you could be moderate to severe and have amyloid. And as long as your doctor thinks it's safe for you to have it, you could have these drugs.
Okay.
Right now, one of the challenges with the drugs is that insurance companies aren't covering it, and Medicare, Medicaid is not covering it. So there's a big push for that reimbursement to happen now, because it does look like they improve outcomes, but it just takes a while for all the bureaucracy to catch up with everything, right?
Yeah. Thank you. Thank you for all the work you're doing.
No problem. Appreciate your question.
Hey, Donna.
Yeah.
So insurance companies don't cover this, or Medicare. What would be, if somebody's in a trial, they wouldn't be paying for this. The trial would be paying for, correct?
Correct.
But if it's outside of a trial, what do you think the cost of this would be?
So that's a great question.
Outrageous, I bet.
Yeah. So the price point on the AdduHelm was $26,000 a year. The price
Oh.
point on the Leqembi, I believe, came in around 12 or 13,000 a year. That I don't believe also I don't think that includes the time in the infusion chair and the nurse's time for giving the infusion, and there's lots of other charges that would go along with it. There are ways to get this. So under Medicare, actually, they will pay for it. So when the FDA approval happened for AdduHelm, and then there was a request to CMS, Center for Medicare and Medicaid Services. There was a request for them to cover it, and so although the FDA approved it, they said, we're going to give you an approval, but you have to go back and you have to do a new trial that will recruit. They wanted more numbers and they wanted different outcome measures. And so they said, we're going to give you 5 years to repeat this trial, basically. And so Medicare have said that they will pay for the scan and the drug if you sign up for that trial. So they're kind of sharing the cost with a drug company.
Got it.
But yeah, as a general rule, if you're in a trial, all of your scans are paid for. All of the doctor's time is paid for. All of the drugs are paid for. And we're recruiting, Sanders Brown is recruiting right now for a study called AHEAD, which is testing Leqembi or lecanemab in people who have amyloid in their brain but don't yet have symptoms. And so if anyone is interested in screening for that to see if they're eligible, the information's on our website. But we have lots of trials. That's not the only trial that we do. And then if people want to pay out of pocket, it's out there and it's available.
Ooh, out of pocket.
A lot of money.
Expensive.
A lot of money. The Alzheimer's Association is going back to CMS now because that CMS decision was made with aducanumab. And now that we have the lecanemab data that is actually even better than aducanumab was as far as learning and memory, benefit. So they're going back to CMS and they're kind of appealing that decision to see if they will cover it. So I think something's going to change this year.
Well, that would be good.
Yeah, we all hope so. Yeah,
that would be good. So you see a lot of these commercials. I mean, and of course they target the time.
I'm going to jump to the last slide, but yeah, go ahead.
Okay. And they seem to target the time that people are watching, like around the news and stuff, for like Prevagen and stuff and all of this stuff.
Oh my goodness.
So save your money or
save your money.
I can save your money. Okay.
Save your money. Okay. So so we had a great keynote speaker at our Marksbury Symposium at the end of last year. And he actually spoke about some of those, supplements and everything, and what things that people should look out for when they see those commercials, right? And so, because a lot of times they'll say that they have done a clinical study, and in that study it showed that that it made your memory better. So if they show like a graph that doesn't have like a placebo group, that's always a big red flag, because there is, with any of these things, and I have it too, if I have a headache and I take ibuprofen, was it really the ibuprofen that worked, or did I just convince myself that I'd taken something? With a lot of these things, there's a huge placebo effect. And so unless the study had a placebo group, you cannot make a statement that it makes anything better. And anytime it's just anecdotal stuff, like, they've paid someone to come on and say, I did this and I took my Prevagen and then things got better. Like, it sounds great. But they've probably paid that person a lot of money to stand in front of a camera and say that. So there are some things. The biggest thing actually is multivitamin, like a single whatever, it doesn't even have to be a certain brand, but a regular kind of multivitamin does seem to have a little bit of benefit in protecting your brain. There was a paper out on that last year. The other thing that we always tell people is everything that you can do to keep your cardiovascular system healthy will also help keep your brain healthy. And then keep your brain active. The brain, if you treat it like a muscle, if we want to strengthen a muscle, we lift weights, we work it out, we do the same for the brain. Crossword puzzles, word searches, social interaction is really big too. All a lot of things that we all should be doing anyway, but that do seem to be really beneficial for Alzheimer's. But save your money on the brain training games. There's a lot of free stuff out there. You don't need a subscription. You don't need supplements like ground up jellyfish or, which is what Prevagen is. None of them really do anything to benefit you.
Got it.
I wish they did. And the other big thing is if something really did work as well as they say, trust me, it would be the headline on every news channel. It would be headline on Fox. It would be headline on CNN, MSNBC. It would be everywhere if we had that.
That's right. That's right. That's right. And in the papers. So
exactly.
Man, yeah, there's a lot of information out here. So hopefully one day, maybe in the future, probably not my lifetime, we all take something when we're like 50 years old, like a pill or something, and it will never ever have a tachyplangle in our brain.
That is, I don't think it will be even in my lifetime, Terry, but I do believe it will be in my children's lifetime.
That's great to